end, maybe. Sorry, probably. So I resume. George Silberschatz is a professor in San Francisco and director of research of a very prolific research team over the years, a very influential figure in psychotherapy research. He's one of the few, I would say, who has from the very start of psychotherapy research in decades ago, worked with case formulation methodologies, being mindful that when we compare the effectiveness of different forms of psychotherapies, that there is something that may get lost, that is the understanding of the individual patient, and also the understanding interventions as they fit to the individual patient. So today, there's no surprise, we will be hearing George Silberschatz speaking about tailoring psychotherapy to the patient. He will be using a specific theoretical framework from psychodynamic psychotherapy, that is control mastery theory, to illustrate his message. It's a huge honor to have you here, George, this evening. I'll hand it over to you after this brief introduction. It's your turn.
Thank you so much, Yuli. The honor is really all mine. I really appreciate being here with all of you. So I'm just going to share my screen. Okay. So thank you. This is the title of my talk, Tailoring Psychotherapy to the Patient in Clinical Work and in Psychotherapy. And I'm just going to review very quickly some of the main points that I want to cover so that you can just follow where I'm going with all this. First of all, I want to focus on the role of adverse experiences in psychopathology. We're going to talk a little bit about psychopathology because, in my opinion, it's hard to talk about psychotherapy without having at least some framework for psychopathology. So I'm going to talk about that a little bit. I'm going to show how people who experience traumas internalize them as beliefs or narratives or schemas or internal working models, whatever you want to call them, which are on a continuum from adaptogenic, they can be adaptive, to pathogenic. And I'm going to show you a case formulation method based on control mastery theory that provides a reliable framework for inferring pathogenic beliefs or schemas and a model about how therapists can best help their patients. And I want to say at the outset that the framework that I'll be talking about is a contextualized model. In other words, it does not privilege any particular techniques. What it emphasizes is supporting the patient's efforts to disconfirm their maladaptive pathogenic schemas. So that's what I hope to cover today. So I want to just share with you some very basic assumptions, just so you know where I'm coming from, that guide my perspective in today's talks. So first, the critical importance of early experiences. In other words, the childhood experiences shape personality. Secondly, the patient's agentic qualities. The patients have agentic qualities. In other words, they make decisions, they carry out plans, they can do this consciously, and they can do it unconsciously. Next is the centrality of adaptation. You're going to see that, from my point of view, adaptation is central and that it's hardwired in all of us by evolution. And related to adaptation, we make conscious and unconscious appraisals because making appraisals is a highly adaptive mechanism for assessing safety and danger. And finally, as you'll see in what I talk about, that context is critically important, both in understanding psychopathology and in understanding psychotherapy. So before we go any further, I just want you to think about this very brief clinical vignette and think about how you might respond to it. The patient in this vignette is a 30-year-old woman who sought psychoanalysis because she fights with her husband. Now, it's interesting because she loves her husband and she's seeking treatment to understand why does she fight with him And why can't she enjoy a sexual relationship with him? Her therapist is a Freudian analyst, and she knows that he is very interested in dreams. So this is the vignette I want you to think about. This is about the 5th session of the therapy. The patient says, "I had an interesting dream last night," and there's a pause. "I also had an upsetting fight with my husband," and now there's a long pause. And she says, "Which would you like me to talk about?" So I want you to think about this vignette. Think about how you might respond to this as a therapist. In other words, try to think about what your response would be now, before my talk. And then I want you to think about how you might respond after my talk. Okay? So we'll come back to this later. So I want to start with adverse experiences, which is the adverse childhood experiences ACEs study. Many of you are familiar with this. I'm going to go over it very quickly, but I think it's a really interesting and important piece of research about psychopathology, because this was done by a man named Ph.D, who's not a mental health person. He's the director of preventive health, medical health, and he was interested in why do so many people do things that are not healthy for their physical health. And he studied a very large sample, not mental health patients, but patients in a medical setting, 9,500 adults. And he developed a simple measure about what kinds of things do they report happened to them earlier in their life. Things like psychological abuse, physical abuse, sexual abuse, violence, and so on. These are just simple questions that he asked in a survey. And the results of this study are really interesting, because when you compare those with 4 or more of these adverse childhood experience versus patients that had none of these experiences, what you find is there were 4 to 12 times the rate of alcoholism, drug abuse, depression, and attempted suicides, and 2 to 4 times the rate of smoking, poor self-reported health, sexually transmitted diseases, and so on. So having these adverse experiences played a very large role in subsequent psychopathology. And this just shows some of it here with the use of illicit injected drugs that people took. So people that had none of these adverse experiences were very, very low in injected drugs. And you can see here, people that had 4 or more of these experiences had a very high percentage of them used street drugs, injected drugs, and so on. The overall conclusion from this study is that adverse experiences are vastly more recognized or acknowledged, and they're powerfully correlated to adult health a half century later. So to quote their conclusion, the ACE study reveals a powerful relation between our emotional experiences as children and our adult emotional health, physical health, and major causes of mortality. So there are many things in the literature that I could point to and review with you about the role of early experiences in psychopathology. I'm just focusing on this one study because it's very powerful. But as clinicians, we know that when we work with patients, people often talk about adverse, difficult experiences they had in childhood and so on. And of course, there are longitudinal studies about this and so on. I want us to all be on the same page about this. So I want to give you a little bit of an experience of we all know what adverse experiences look like, and I don't need to tell my colleagues in Ukraine about adverse experiences in current reality, but I want you to look at this simple experiment done by Tronick called the still face experiment. And I'm going to play this for you just to give us all a feel about some of this.
In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age. Oh. And she gives a greeting to the baby gives a greeting back to her. Yeah. This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, come on, why aren't we doing this? Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay, so I show you, this is a very brief clip, and you could see, I think in the first even 2 or 3 seconds when the mother has this still face, how the baby reacts in a like almost shocked kind of way. And the reason I show this is just like a 45-second period of a mother being neglectful, if you will, in quotes, of the baby. But I want you to imagine what it would be like and what the experience is like for someone who grows up in a household like this, and the impact that that would have on their own views of themselves and so on. So how does psychopathology develop? So I would say people experience adverse or traumatic experiences, for example, parental neglect, like in this brief vignette that I showed you. They develop internal working models. This is what Bowlby called it, i.e. beliefs to make sense of the experiences. In other words, my parents neglected me because I was bad. This is what children do. And I'll put up here a quote. This is from the magazine just months ago, from a woman named Dr. Becky Kennedy. She's quite a popular psychologist who works with children and parents. And I really like this. In a one-paragraph summary, this is a really good flavor of what I'm talking about. So this is what, this was in an interview in the New Yorker magazine. Kennedy says, our kids are oriented by attachment. How they get their safety and security is through their attachment with us. We give them food, shelter, all the things they need to survive. And so they're always paying attention to the status of our relationship with them. In a moment when we yell, instead of them feeling safe and secure with us, all of a sudden, the person who gives them safety and love and security becomes a person who's delivering fear. If we don't repair, a kid has to find another way to get back to feeling safe again. They have to tell themselves a story to get back to that secure place. And the story kids generally tell themselves is that it was their fault. They think, I'm a bad kid, I'm bad inside, I'm unlovable, I made bad things happen. Because then at least they can still believe that their caregiver and really the world around them is safe and good, which is something they need to preserve their own survival. So this is a very succinct summary of what happens to kids in an adverse experiences. And what she's implying is there's something adaptive in that moment for the child to blame themselves instead of blaming their parents. Because by blaming themselves, they can still hold on to a view that there's someone good in the world that they can rely on. So it just gives you another flavor about the role that adverse experiences can have in children. So let's talk a little bit about trauma. And again, I feel a little awkward talking to our Ukrainian colleagues about trauma, but so trauma is a deeply distressing or disturbing experience in which a person's emotional and coping strategies are overwhelmed. So there are two kinds of traumas that people talk about in the literature. There are shock traumas, which are powerful single incidents, accidents, serious illnesses, war, death of a loved one, and so on. And stress trauma, ongoing repetitive experiences that a person grows up with, such as growing up in an alcoholic family, of emotional neglect, chronic abuse, and so on. Those are two kinds of traumas that people talk about. So what I want to emphasize here, that the concept of subjectivity in trauma, in other words, it's the subjective experience of constituting the trauma. Two siblings from the same dysfunctional family who experience identical adverse parenting, one may be traumatized while the other is left unscathed. So subjectivity is very important here. And what accounts for the difference? Why is that? And I think for me, it's the concept of a schema, that there's a structured pattern of thinking, feeling, or behaving that organizes how we perceive and experience the world. So I don't mean schema therapy. A lot of times when I say schema, people immediately think, oh, you mean Jeff Young and schema therapy? No, no, no. The concept of schema, excuse me, is very old. Piaget wrote about it, of course. Bartlett wrote about it. And of course, even Immanuel Kant wrote about it in the 1700s. So the American Psychological Association describes schema as a cognitive structure used for comprehension, perception, and interpretation of stimuli. That's what a schema is. And the schema helps us to understand and make sense of what it is that we see and experience. So the relationship between trauma and psychopathology is often thought of like this, that there's a trauma and it leads to psychopathology. And this more subjective view of trauma would suggest that no, there's a trauma that's mediated by the particular schemas that people develop, and it's that leads to potentially to psychopathology. So people experience events differently at this point. That's really what I'm trying to say. Okay, let's turn now to psychotherapy. How does therapy work? Well, the first thing I want to say to you is that, and I think this point should be emphasized more. I think we do, as psychotherapy researchers, we could do a better job in our public relations, because the first thing I want to point out is that therapy, just in aggregate, forget about different kinds and all that, but in general, therapy works. So an average untreated person who has difficulties is going to be much, much worse off than the average patient who does get therapy. Okay, so it's important to keep that in mind. So what kinds of studies have been done to assess why therapy works? Well, there are many studies of techniques and brands. There are studies about the relationship, so-called non-specific factors. And finally, there are studies about the therapist and therapist effects. For brands, one of the early studies was the Treatment of Depression Collaborative Research Program done by the National Institute of Mental Health, which basically compared, the NIMH was interested in the question, in treating depression, which treatment is best? I mean, it was a question, this was done in the 1980s. So they compared cognitive behavioral therapy, interpersonal therapy, imipramine, which was the drug of choice at that time, and placebo. And I show you the results here, but I want you to keep in mind that a lot of time and effort and money went into planning this study. People invested very, very heavily in designing this study, and it was methodologically considered state of the art. But what was the outcome? This is the percentage of patients improved over here, and this is what we found. There were no differences between any of these four conditions. A rather striking finding, and people didn't like, of course, and everyone complained after, no, the study wasn't good, this wasn't right, that wasn't right. The cognitive behavior therapists were particularly upset about it, but these were the findings. Now, I start with this early finding, but things have not changed very much. So in 2012, the American Psychological Association did a review of all the psychotherapy research, and this was their conclusion. Comparison of different forms of psychotherapy most often result in relatively non-significant difference, and most valid and structured psychotherapies are roughly equivalent in effectiveness. And Bruce Wampold has taken a step further in a book called The Great Psychotherapy Debate. And this is a slide from one of his recent publications. If you look at specific ingredients here, which are techniques or the adherence to a treatment protocol here, or even rated competence, and you look at what is the effect size in terms of how much outcome is accounted by these things, it's very low. Specific techniques is practically zero. But what's high? Goal consensus, the patient and the therapist collaborating on what the goals they're working on and so on accounts for an enormous percent of variance. So in other words, despite the overwhelming evidence that therapy brands or techniques don't explain outcome, what is the gold standard in psychotherapy research? And the gold standard is basically this: randomized controlled trials, horse race studies, trying to see which one is best, comparing brands and techniques. And yet we know from what Wampold showed about meta-analyses that brands and techniques don't really account for much variance. So what I want to draw our attention to next is what might the research look like if clinical thinking was incorporated into the research. In other words, if we thought more like clinicians, we wouldn't be doing these horse race studies. Most clinicians don't really think that's a very good way to go. But what would the research look like if we were trying to think about things more clinically? And I'll give you a hint. The psychotherapy research would look very, very different. So the first thing we'd have to come to terms with is that the homogeneity assumption is a myth in psychotherapy. So in most psychotherapy studies, in these horse race studies, randomized trials, you get a very large group of patients. They're thought to be homogeneous. I submit to you they are not. They get randomly assigned to treatment groups. There's follow-up, and then you compare the results. But the homogeneity is a myth because patients are not homogeneous. They experience events differently, even if they share the same diagnosis. Therapists are not homogeneous. They're very different. And treatments, even when they are manualized, are not homogeneous. So if you think about individualized approaches, this is from the education research. I really like this quote from Ignacio Estrada. If a child can't learn the way we teach, maybe we should teach the way they learn. And I think that begins to get closer to the way a lot of clinicians think. This is a very old concept I'm talking about here. So this is thousands of years old. This comes from Buddhism. It's a symbol. I mean, I live in California, so we see this symbol all over the place of what they call a bodhisattva. This is a particular one called the bodhisattva of skillful means. And I've always wondered, why does this thing have so many arms? And the reason in Buddhism is that what they're trying to convey here is that in order to teach Buddhism, you have to tailor it to different people. That these arms all contain different things. Some of them contain a knife, some of them contain scissors, some of them contain kindness, and so on. So this is an old concept from Buddhism about the way things are taught has to be tailored to the person that you're teaching. Thousands of years old. Hippocrates said it's more important to know what sort of person has a disease than to know what sort of disease a person has. Thomas Aquinas, the theologian, said what is received in the manner of the receiver. And then more recently in cognitive neuroscience, you have this man, Anil Seth, a very well-known cognitive neuroscientist, who says we don't see things as they are, we see them as we are. So all of these things point to the subjectivity that I'm speaking to here. So applying this kind of personalized approach to psychotherapy, what would that look like? Well, instead of tailoring the patient to the treatment, which is what we do implicitly in these horse race studies, we should be tailoring the treatment to the patient. So clinical wisdom shows us that responsiveness, that is the therapist reacting in a manner that is appropriate or right for that particular person, is a predictor of therapeutic effectiveness. So in psychotherapy, responsiveness refers to the therapist's capacity to tailor and modulate therapeutic processes and interventions to patient-specific problems, needs, goals, and sensitivities. But the critical question is, how can the therapist know what is responsive for that particular patient? So there's a whole field that I learned about just a few years ago called relationship science. It's not a clinical field. It just looks at what happens in dyadic communication. When any two people are communicating, what is going on in that process? So they talk about two dimensions of response, and I'm thinking here particularly of the work of a man named Harry Rees. So he talks about two dimensions of responsiveness. There's intended actor responsiveness, and then there's the perceived partner responsiveness. So a therapist, for example, can intend to be responsive to their patient, but it's what the patient perceives that is particularly important. And Rees would say it's the only thing that's important. In other words, that the partner perceived responsive is the primary thing that matters. And that goes back to what Aquinas said, that what is received in the manner of the receiver. It's the only way that things are received is by who's receiving it. So the question, how can a therapist develop a better understanding of what a patient will perceive as responsive? That's the critical question. It's a critical question clinically for us as clinicians, but I would maintain it's also a critical question for psychotherapy research. So I'm going to talk to you a little bit about control mastery theory because it helps us understand patients' experiences and how the patient's experiences shape their perceptions, and that this understanding serves as a guide for responsiveness. So first of all, what is control mastery theory and what it isn't? So control mastery theory is a model, it's a framework for how psychopathology develops and how psychotherapy works. It is not, and I really want to emphasize this so we're very clear about this, I'm not talking here about a new brand of therapy, and moreover, it doesn't privilege particular techniques at all. What it emphasizes and what it does privilege is the importance of therapists being responsive to the patient's problems, needs, and goals, what I'll talk to you about as the patient's plan. So this theory started with a very interesting observation that Joe Weiss made in a very short paper published in 1952. And the question that Weiss took up is, why do we cry at the happy ending of a movie? People can go to a movie, and during the sad parts, they may be quite, just following things, but not particularly emotional. And then when the happy ending comes, they cry. And the question he asked is, why? Why would people cry at the happy ending? And the answer he gave was that the happy ending makes it safe to experience the grief and sadness that they felt during the saddest part of the movie. It's about safety and perceptions of safety and the way a person regulates their affects based on their perceptions of safety and danger. So this paper was the cornerstone. The paper was called Crying at the Happy Ending. It was the cornerstone for the development of control mastery theory, and it led to many important insights in clinical applications. For example, why do we have pleasant dreams during periods of extreme stress and frightening dreams when the stress has passed? Again, it's the concept of safety and the way people regulate what they do based on their perceptions of safety and danger. And similarly, what are the conditions that allow our patients to lift defenses and bring up painful feelings? Again, people are regulating and appraising what is safe and what is dangerous. So these are the basic building blocks of the theory. In other words, with these 6 elements, you have the theory in total. First comes adaptation. I'm going to talk about each of these a little bit more in a moment. Attachment and this perceptions of safety and danger that are rooted in attachment. The role of trauma and adverse experiences, the kinds of beliefs or schemas that people can develop from those adverse experiences, the kind of appraisal, vigilance, and testing that people are always doing based on their beliefs, and then finally, the kinds of corrective experiences that people can have that allow them to overcome some of those pathogenic beliefs. So these are the basic building blocks of the theory. So let's begin with what I call the adaptive imperative. And this is basic Darwinian biology. It really begins with Darwin and the fact that we, all living things, not just humans, but all living things are hardwired by evolution to adapt. In other words, you either adapt or you die. And so evolution wires us to adapt to our environment and to our reality. So adaptation is the foundation. It's the cornerstone of control mastery theory. Everything rests fundamentally on this concept of adaptation. So let me just give you a few basics about human adaptation. In human, the key to adaptation are attachment to caregivers. We can't survive without our caregivers. In ecology studies, people say there's no such thing as a lone monkey in the environment. A lone monkey is a dead monkey. So attachment to our caregivers is critical for adaptation, and forming a conception of reality in adaptation, in those early experiences, we form a conception of reality, and those are our beliefs, or what I call our schemas. So a reliable model of reality, if we're going to survive and adapt, has to be guided by learning about what is safe and what is dangerous. And we constantly appraise, again, this is adaptive. We have to appraise people and situations in an effort to assess safety and danger. So appraisal is critical for that process. And finally, the primary forum for developing our conceptions of safety and danger are our relationships with parents or caregivers. So if you think back to that quote I read you from Dr. Becky, that's what she was talking about. And this isn't to say that people cannot develop psychopathology based on experiences with siblings or friends or that kind of thing. No, I mean, all of those things happen, but our relationships with our parents and our caregivers are critical in this. And then finally, there are adaptogenic versus pathogenic models of safety and danger. So one thing we have to be clear about is what was once adaptive can become pathogenic, and what is currently pathogenic was once adaptive. And I think you could get that from the quote I read you earlier from Dr. Becky, which really comes from a famous psychoanalyst named Fairbairn, who said that it is better to be a sinner in a world ruled by God than to live in a world ruled by the devil. So in other words, for a child, it is adaptive for that child to see themselves or to blame themselves for the way they're being treated, because then at least they can hold on to the hope that the world is a good place. Whereas if the child were to feel like, no, I'm good and my caregiver is bad, that would be a very, very difficult environment to grow up in. So that's why I say what was once adaptive can become pathogenic. And I think when you look at what's currently pathogenic, you can often find the roots of how it was once adaptive. So in the control mastery framework, this is the basic model of psychopathology. It's relatively simple. People have adverse experiences of all kinds, often with parents or caregivers, but it can be with siblings, with peers, and so on. As adverse experiences, when they can develop pathogenic schemas, or Bowlby's concept of internal working models. And the schema, when I talk about a schema or a pathogenic belief, I'm not just talking about simple beliefs. It's a constellation of behaviors, relationships, emotions, and so on. So examples of pathogenic schemas, someone who is treated badly in childhood sees themselves as ugly, worthless, a failure. They see their view of the world is that no one loves me, no one ever will love me, I'm hopeless because things will always be this way. This is a particular kind of depressogenic schema that you see a lot in very depressed patients. So we can think about core organizing pathogenic kind of schemas that develop in childhood and persist for a lifetime. I'll just give you, I'm going to go through this quickly, like this patient, Linda, who was an unwanted child. Both parents wished they'd never had her. They regretted not having an abortion. This is what she grew up with. And so her pathogenic schema, of course, is she believes that she is unlovable. Or another patient who was a particularly precocious, very, very intelligent child, and his father reacted very poorly to his probing questions about the way things worked, and the father would get very upset about it. And so this patient believed that he had to hide his intelligence in order to avoid hurting people that he loved and needed. So the building blocks of control mastery theory, I've quickly covered these first four about adaptation, safety and danger, trauma, and pathogenic beliefs. I want to talk a little bit about vigilance, appraisal, and then corrective experiences. So what's the theory of therapy? First, patients come to therapy in order to disconfirm their pathogenic beliefs and master their problems. So sometimes when I talk about this, particularly in psychoanalytic audiences, they say, wait, you mean to say that you think patients come to get better? And I say, yes, that is my belief. That isn't to say it's easy. And there can be many things that get in the way of that. But the theory infers that that is a fundamental motivation in people coming to therapy. So people come to get better and have a plan for doing so. And their plan is essentially, in its simplest form, the plan is just to disconfirm their pathogenic beliefs. In other words, patients suffer from these pathogenic schemas. I'm lovable, I'm unlovable, or I'm a bad person, and so on. And they come to therapy because they don't want to have these kinds of views of themselves. And so this is basically what you can think of as the mastery motive in control mastery theory, that people want to disconfirm their pathogenic belief. But when I say that, of course, I realize that it's not easy. So I keep that in mind as well. So how do patients work to disconfirm their pathogenic beliefs? Well, first, I mean, the one thing that's very familiar in a lot of therapies is, well, they could develop greater understanding. In other words, the role of insight. That is one way that people can learn something new about themselves, and that can help them to begin to disconfirm those views. People can also test their pathogenic beliefs and schemas. They can test them in the relationship with the therapist. They can test them in other relationships in the hope that to see that they are not borne out. And finally, people can have corrective relational experiences, or what Alexander called corrective emotional experiences. And again, that this could happen in the therapy, but as I've been rereading Alexander lately, he often pointed out, he made a big point of saying that these don't just happen in therapy. The therapy is designed to prepare the patient to have more corrective experiences outside of the therapy relationship. So these are just different ways that patients can work to disconfirm pathogenic schemas. So I told you we think about a plan, and I want to just give you a flavor of what we think of as a plan formulation. This is just a way of organizing, if you will, the patient's narrative, or what is the patient's inner world. It's a way of putting that together in a way that we have found helpful. First, we want to think about what are the patient's adaptive goals. In other words, people come to therapy, they have all kinds of goals. Some of them may be maladaptive, but people do have adaptive goals, and these can be conscious as well as unconscious. And then next, what gets in the way? If people have adaptive goals, say to have a better relationship or to feel better about themselves, what gets in the way of that? And of course, that's the pathogenic schemas that I've been talking about. And then where do these pathogenic schemas come from? As I've already given a sense, they come from adverse experiences that people have had. How do people work to overcome these pathogenic schemas? They can test them in the therapy and outside of the therapy. And then finally, there are what kinds of new experiences or insights or so-called corrective experiences will help the patient to disconfirm their pathogenic schema. So there's nothing magical about it. I mean, in a way, this has a particular logic to it. You know, you start with what does the patient want? What's getting in the way of the patient achieving that? Where do those things that get in the way come from? And how is the patient going to work to overcome those things? That's the essence of what we mean by a plan formulation, just to demystify it a little bit. Okay, so a few very brief examples of plans and plan formulations. An abused child, the child who was abused, has a plan to disconfirm the pathogenic belief that she deserved abuse. Okay, and again, think back to that interview I read to you with Dr. Becky, and I think you can see that in there. A patient, Myra, wanted to leave a poor relationship she was in with an alcoholic man. She disconfirmed the pathogenic belief that she would ruin him if she left him. And that pathogenic belief came from a feeling and a worry she had when she was growing up about leaving her depressed mother. So this is someone who grew up with someone that she felt she had to take care of. If she's in a relationship that's pretty dysfunctional, but she has a hard time leaving because she's afraid, she's worried about ruining him. Okay, I think that gives you enough of a flavor of it. So this, in a nutshell, here is the conceptual model, if you will, of control. This is the whole thing now. I showed you the one of psychopathology. This is now the whole package. So adverse traumatic childhood experiences, for example, a depressed parent, illness, emotional neglect, dysfunctional family, all kinds of traumas can lead to pathogenic beliefs or schemas, internal working models. The patient comes to therapy, they're motivated to disconfirm these. They want to change those internal working models. And then the hypothesis is that the degree to which therapist interventions help patients to disconfirm their pathogenic schemas is what leads to positive outcomes. Whereas interventions that confirm pathogenic beliefs lead to poor outcomes. So this begins to give you a different way of thinking about what accounts for the effectiveness of psychotherapy. And I'll show you a little bit of research in a moment that speaks to that. All right, so the control mastery theory is a very case-specific model. It's a personalized model. The context of the individual patient's traumas, pathogenic beliefs, and needs is central to the theory. So in other words, context matters. Context is everything. And therapy techniques, this is a very important point, that can be helpful or harmful, depending entirely on context. An intervention that's helpful to one patient can be harmful to another patient. So you can't look at techniques, in my opinion, in a decontextualized way. The only way that thinking about techniques is useful is in a contextualized way. So a few brief examples of this. In CBT, in cognitive behavior therapy, we think about homework and the value of homework in cognitive behavior therapy. I'm not opposed to homework, but consider a patient who comes to therapy, to a CBT therapy, who's always been very driven, always had to be perfect, always had to be the best. And she, in the first few meetings, she does her homework and it's the best homework. And she's really, and then one day, after a couple of months of therapy, the therapist asks about her homework, and she says, I didn't do my homework this week. For that patient, that's an achievement. It's not a problem that she doesn't do her homework. It's a huge achievement that she could just relax and not be so driven about doing homework and always being the best. This is a beautiful paper written by a colleague of mine, Endangered by Interpretation. So there are, in psychoanalytic thinking, we think interpretations are everything. You know, it's the key to successful therapy. But Cynthia Shulkret wrote this paper that no, there are patients who are actually endangered by interpretation. So she was focusing on narcissistically vulnerable patients. And the narcissistic, vulnerable patient can't stand the idea that someone else is thought of something that they themselves have not thought of. And when the therapist makes interpretations to some of these patients, they feel belittled. They feel less than, and it makes them feel worse. So again, you have to look at these things contextually. You can't look at them. You can't look at something like interpretation or homework or self-disclosure or any intervention in a decontextualized way. Okay, so a couple of clinical vignettes to sort of just flush out what I'm trying to get at here. This will illustrate why context, in case you haven't gotten it so far, this will make it very clear about why context is so important. So this is an actual case. A young woman sought psychotherapy because she felt, quote, excessively self-contained. She always had to rely on herself. And she wanted to be able to rely more on friends and loved ones for help. That's what she was coming to therapy for. She reports growing up as an only child in a very dysfunctional family. She recalled asking her parents for help or advice when she was a very young child, and they responded angrily. And they would say things to her, we don't know what to do. Why don't you go figure it out for yourself? So you can imagine a young child getting answers like this from a parent and what that would do to them. So she diligently engages in therapy and begins one session by saying, I'm really not sure what to talk about today, and I would like to get some guidance from you. Do you have any suggestions for me? Now, how to respond? What do you say as a therapist, keeping in mind the context of what I told you about this patient? So a case formulation is a way of personalizing, it's a way of contextualizing therapist interventions. So remember, I showed you these elements of a plan formulation, the goals, the schemas that interfere with goals, traumas, and how the patient works. So let's develop just really quickly a very rudimentary plan formulation for this particular patient, just based on what I've told you. Her goal, we know what it is, it's to be less self-contained. and to be able to rely more on others. That's what she wants. That's what she wants help with. What's getting in the way? She had these adverse experiences of neglectful parents who couldn't provide developmentally appropriate help and guidance, leaving her entirely on her own. What's the pathogenic belief? What's the internal working model if you grow up in a family like that? It's very obvious. I can't rely on others for help. I'm on my own. So can I rely on you? Now she's in therapy, right? And in asking for some guidance or help, what she's really asking for here is, can I rely on you, the therapist, for help and guidance? So remember when I talked about appraisal and testing? This patient now is trying to find out, here I'm in a relationship with someone, they've been working for a couple of months together, and now she doesn't know what to talk about, and she's asking for help and guidance. Can I rely on you for that help and guidance in a way that I could never rely on my parents or others in my life? Begins to suggest a way of responding, right? So what's the helpful intervention? Well, let's look at what the therapist did. The therapist was a non-directive kind of therapist. She adhered to a very non-directive stance, and the therapist says, what would you like to talk about? Now, remember when I showed you about actor intended responsiveness and partner perceived responsiveness, right? So this is intended by this therapist as a helpful thing. This is the way she's trained. We do things non-directively. We ask the patients what they want. It's very, very well intended on her part. But how is this patient going to perceive it? Based on her experiences, how is she going to perceive a question like, what would you like to talk about? So the therapist's intervention reflects a top-down, it's technique-driven, it's a totally decontextualized approach. You should always be non-directive, right? It fails to take into account the context of this particular patient and what she previously shared about her childhood traumas. The more helpful intervention for this patient, just for this particular patient, because of this context, would be to provide guidance, which the patient would likely experience as a corrective emotional experience and passing a very important test. So in other words, by the therapist saying, providing some guidance of what to say, this patient, again, this doesn't hold across the board, but this patient would experience that as a corrective emotional experience. Okay, now I want to go back to the little vignette that I gave you at the beginning. So this was a 30-year-old woman who sought psychoanalysis because she fights with her husband. She loves her husband. She'd like to understand why she fights with him. So she sought out a treatment with a Freudian analyst. And in the first few sessions, she described the pattern of fighting with her husband, her inability to enjoy sex, and gave a detailed history of her family of origin. She grew up with an extremely narcissistic father and a mother who obliged him, just went along with everything he wanted. And the family ethos was, you have to go along to get along. That's what it takes to maintain harmony in the family. So this is the 5th or 6th session, and the patient starts out, this is the vignette I showed you early. The patient starts out, I had an interesting dream last night. I also had an upsetting fight with my husband. And there's a long pause. Which would you like me to talk about? So just think about the narcissistic father for a moment, but let's just use what we've learned about this patient, and we'll develop a very quick, very rudimentary plan formulation. What's her goal? She wants to improve her relationship with her husband. That's what she's coming to therapy for. What are her adverse experiences? She has a very narcissistic father. She had to do everything he wanted in order to get along with him. The pathogenic belief, the internal working model that she developed is, in order to preserve my relationship with my father and more generally with a man or people, I need to subjugate myself. I need to do what they want, not what I want. That's the way you preserve relationships. So she's asking the therapist. Now, this is, remember, I talked about appraisal, about safety and danger. And she's trying to find out in this therapy, or very early on, will I need to subjugate myself here with you the way I had to with my father? That's what this is fundamentally about. Which would you like me to talk about? And obviously, a helpful intervention, again, for this patient, now, given this context, is which would you like to talk about? That would be a corrective experience for this patient, because now, now I have an experience with someone who's more interested in what I want than what they want. So when I say context matters, I mean that the identical intervention, what would you like to talk about, is extremely detrimental in the first case and extremely helpful in the second case. So something as simple as, what would you like to talk about? And we should talk about, I think we should talk about what you want to talk about versus helping the patient and giving her guidance. It really, the same thing is helpful in one patient and detrimental in the other. And this is just a way of putting in clinical form the kind of thing that Wampold was showing in this slide. The particular technique is not going to get you very far in explaining what's effective, but something about the degree to which there's some consensus between the patient, or in my language, the degree to which there's some compatibility in the way the patient is working in the plan formulation accounts for a great deal of outcome variance. So the very powerful effect size of goal consensus really supports the view that the therapist's ability to understand and facilitate the patient's goals is the strongest predictor of outcome. And our research group has done studies. So far, I've just focused your attention on why this is important clinically, but now I want to show you how you can apply the same thinking in research, because our group has done studies using case formulations, and we found very strong correlations between therapist interventions that are responsive to the patient's goals and therapy outcome. And I'm just going to very quickly show you some of that, and then we will have some time for questions and discussion. So just some background and findings from our research group process studies. Therapist interventions that are responsive to the patient's therapy goals, what we think of as the patient's plan, are predictive of in-session progress. And sessions with a higher frequency of these kinds of interventions are significantly more productive than sessions with fewer interventions. So this is what it looks like in a single case. This graph here is what the degree to which the therapist is disconfirming pathogenic schemas. And then this is the patient's functioning, in this particular case, the patient experiencing scale. So you can see that as the therapist is moving up in this dimension that is disconfirming pathogenic beliefs, the patient functioning goes up. And when the therapist degree of, in other words, when the therapist is confirming pathogenic beliefs, doing poorly on it, the patient's functioning goes down. And that goes across, this is session by session. This is the same thing in a different case, showing you the same kind of pattern. And this would be it with 3 individual cases. And you can see the correlations of these things are actually quite high. But what all of this research entails is developing a formulation of the particular case, just like I showed you in the clinical examples, and then using the formulation to guide the ratings of the therapist's interventions. So what I do there, findings. I also want to draw your attention to outcome findings, because it's obviously useful to show that some of these things help explain what happens during the therapy, but the question is, what does it do in terms of predicting outcome? And I'm going to go through this very quickly, but this study was based on 39 patients, 16 experienced therapists, and patients were screened by a clinical evaluator before the treatment, and the patient, the therapist, and the clinical evaluator filled out a variety of forms before and after therapy. So the therapist's interventions were rated in this outcome study by a brief summary of the intake interview and the plan formulation. That was the basis for making ratings of therapist interventions. And then we selected sessions, 4 sessions from different phases of the therapy: an early session, early middle, and late session. And what judges rated using the plan formulation was just therapist comments from the session. No patient material was included. And all these judges did this independently. They rated the plan compatibility of the therapist's interventions for the session as a whole. So in other words, what people are rating here for the session as a whole is, to what degree did the therapist disconfirm the patient's pathogenic schema? And that was done on a 7-point scale. And all of this was done with high degrees of reliability. So we look at outcome in several different ways. There's symptomatic changes, what we call individualized changes, and global changes. And these were the correlations. So you can see with symptom changes, the more the therapist disconfirmed pathogenic beliefs, the less symptomatic the patient was. And the same is true for global changes, individualized changes. And then this is an interesting part of the study. We asked patients at the end of the therapy about their experience of the therapy. How freely were they able to talk to the therapist? How well did they feel the therapist understood them, and so on? And you can see here that at the degree of plan compatibility of the therapist's ratings predicted, in other words, highly correlated with what the patient experienced at the end of therapy. So these were very high correlations. They explain a great deal of variance, both in outcome and in the patient's experience of the treatment. I want to show you one more thing before we have some discussion about this, which is the role of therapist effects. So the question is, we know that some therapists are more effective than others. These have been called super shrinks in some forms. Some therapists are clearly more effective, and these therapist effects actually trump so in a clinical trial, if you're comparing CBT and some other form of treatment, the therapist effect is more powerful than the treatment effect. And if we wanted to optimize psychotherapy outcomes, it would be useful to understand, what are these super shrinks doing that their less effective counterparts are not doing? In other words, what accounts for their effectiveness? And just to give you a flavor of how powerful these therapist effects are, this isn't just clinic data from many, many therapists, many, many patients. The difference between the most effective therapist and the least effective therapist is a factor of 10. In other words, the most effective therapists are 10 times more effective than the least effective therapist. So it's a big effect. I mean, this happens in almost all studies that I'm aware of, that therapist effects are powerful. So there's no question that some therapists are more effective. They have consistently better outcomes than others, but little is known about how these so-called super shrinks achieve their superior result. To me, that's the most interesting question, right? What in the hell are they doing that the less effective ones are not? So the hypothesis we were interested in studying was that the super shrinks interventions tend to be more plan compatible than those of their less effective counterparts. So this is just a hypothetical. If all therapists were equal in terms of their effectiveness, this is what it would look like. If outcome were on a z-score, on a standard score with a mean of 0 and standard deviation of 1 in the positive direction and -1 in the negative, everybody would be here. That's by definition if there were no therapist effects. But it doesn't work that way. And here's some real data. This was just a study that we carried out in our research group. This is just to explain this a little bit, there were 16 therapists in this, and what's rated down here are their mean outcome scores for their whole caseload, not a particular patient, but the therapists had caseloads, and what we're looking at here are their outcome scores for the caseload as a whole. So what you see here is that there are therapists, clearly I put them in green, who are more effective. In other words, they're above the mean of 0. And there are clearly therapists who are less effective. The mean for their caseload, in other words, all of the patients they see, is below 0. So there's a big difference between these two. And what accounts for their difference is that all of these therapists up here had some training in case formulation. All of these therapists did what I showed you in the two clinical examples that I gave. They took context into account, and they used that context in terms of their intervention. For those of you who are more statistically inclined, this is a very, very big statistical difference between the most effective and the least effective therapists. I wanted to leave some time for questions and discussion. I thank you for your attention. I've thrown a lot at you, and this is a good time for questions, comments, feedback, or anything you'd like to bring up. So thank you very much.
Thank you so much, George. This has been very inspiring, listening to every word attentively. So let's turn to the group. You can also write in Ukrainian, and maybe somebody could translate if you prefer writing or speaking. And then we in the English channel, George, you should be able to hear the translation directly. Any comments, George, in your experience?
I take that to mean that it's so clear that one can't even question what I said, but that's not true. So don't be shy.
It was very clear too. Doesn't exclude any questions, so please go ahead. Any questions you may have? People say thank you, and I don't know what thank you is in Ukrainian, but it may be what's been said here.
Yes, there are lots of thank yous.
I simply want to say that I really was fascinated by this talk by George. Really, it was so condensedly clear, was extraordinary in my opinion. I enjoyed it very, very much. I don't have a question right now, but I will think about it. But I simply want to congratulate with George.
Thank you. Thank you very much. I think it's, to me, it's one of the great ironies. I've really struggled with this for a long time. Psychotherapy, if you think about, whatever your point of view, whatever brand of therapy you follow, should be psychotherapy is the most personal thing there is, right? We hear things in our work with patients that they often don't tell anyone else. It's a very personal experience. And yet, so little of the research and it takes that into account in terms of context. It's like a complete irony to me. And I think Nancy McWilliams once talked about this, that a strange thing happened to psychotherapy when we got absorbed in randomized trials. Because in a way, maybe we need this, she was talking about psychodynamic therapy, but maybe in a way we needed randomized trials to show that something that we're doing is working. Okay, that's fine. But she said, I may be misquoting her, but basically she said, but look at the price that we have paid for that. Because the price that we have paid is we think of, well, we have a treatment for these disorders, that these disorders need this treatment or these disorders need that treatment. And we completely lose sight of who the patient is that's being treated. And I just find that very, very ironic.
Yeah. I was very much struck by what you said, something that I always thought myself, that many analysts don't ask themselves how the patient perceive what they say.
Exactly.
Very, very often. They simply have a standard technique and they apply it and they don't understand. Then I've asked how the patient can understand what they say.
Exactly.
It's incredible. Still today, the many analysts do that.
Yeah. And it's not just analysts. I mean, there are a lot of top-down. That's why I just use that non-directive kind of. But CBT, I mean, people it's part of the branding of psychotherapy that's happened, that people feel they have to just adhere to this brand. If you're an emotion-focused therapist, you must just focus on emotion, forget everything else. But yeah, I think it doesn't make sense to me.
George, there is a question from one of the participants in the chat from Alexandra Kovalenko. And the question is, can we correct the length of session according to the client and according to the context? For instance, if a client needs more time to feel relief, can we have longer sessions?
I mean, I would say yes, that we should, I believe that we should do whatever is helpful to the patient. And if patients need more, I mean, the difficulty most of what I do is open-ended therapy. I have to confess, that's what I do. But we also have to take into account the realities that, of course, I mean, you can't do open-ended therapy for everyone. And there are many of us that work in settings where you're constrained by how much you can do with a patient or how long you can work with a patient. And I think that's just a reality that we have to find ways of dealing with. But I favor doing whatever helps a patient is what I'm in favor of. I think it's when I talked about that relationship science work by Harry Rees, he studied medical doctors and patients. And the only thing that accounted for health outcomes was how the patient perceived their doctor. And so I take the concept of the patient's perception as I really give that a tremendous amount of weight. And so in anything, I mean, I think for some patients, if you share something about yourself, it means a great deal to them. It means that they may feel that you care about, whereas, for other patients who had very narcissistic, it may not be particularly helpful. But I think the key point for me is what's going to be helpful for this particular patient, and do I have a framework, at least for thinking about that? That's what I think is so critical.
Another question, Ms. Irena Lihus. There is a question, and I cannot translate it because the guy is talking, sorry.
There's still the idea that you don't have to give experiences, but simply understanding the patient. And to give corrective experiences is something that is not good, is not psychoanalytic. Many people feel in the same way today still, unfortunately, because of the Alexander that was in a way excommunicated by the psychoanalytic church many years ago.
Exactly.
Can I suggest to go back to Nastasia?
There is a question. Yes, there is a question. Thank you.
Go ahead.
A question from Irena Lihus. She's asking, what sources would you recommend to be in the loop of all new researchers to understand what's going on in the field?
I'm sorry, I missed the first part. What would I,
What
you asked?
sources? What sources? What books?
What
George,
courses?
sources, not courses. Sources like books, maybe, or magazines, or whatever it is.
Hmm. So there are publications, and I could maybe send them to Yuli or Michal after that. I could send some. I didn't prepare a reference list, but I could send some papers which you could download. I mean, make them totally available for free from our website. That would further amplify some of what I was talking about and give more details about just how we do some of this research. But I think the Bruce Wampold work is very. I mean, Wampold's work is to me very interesting because it shows the difficulty in the way research is done. He doesn't give very good solutions of how to do it better. He's a very good critic of the research. He doesn't really give good alternatives. And if I were to give you guys some papers to consider, I would want to give some that give you good alternatives. But some of the work, that Yuli Kramer has done work in this regard. Franz Kraspar and Klaus Grave from Switzerland were very, very far ahead of the curve in psychotherapy for taking into account. They also have a concept of the patient's plan. It's a little bit different when I talked about, but they have a way of doing these things in a case-specific way that is very, very helpful. And I think some of it didn't go very far, but some of Lester Luborsky's early work on the core conflictual relationship theme. What's interesting to me is that this kind of thinking, that's why I showed you the Buddha slide, and so it's been around, or Aquinas, it's been around for so long, and it's just been so hard for people to really grab hold of it, because doing research in this way, as Yuli can tell you, and certainly as I can tell you, is very, very hard. It takes a lot of effort and a lot of time, and I think it's worth it, because we find findings that are interesting and relevant to clinicians. But I think it's just been, I remember when I was starting to read Lester Luborsky's work, and I tried to look at where did his idea, he studied things like the symptom context method. It was very interesting work about when a symptom develops in the course of a therapy, and the symptom he focused on in one example was momentary forgetting. Let's say the patient's talking and they say, I forgot what I was going to say. He could identify that, hold it and look at what was the context for that, which I always found very interesting. But then when I dug into it about how did he get that idea? And I looked further back, and it was Margaret Brenman and Merton Gill, when they were at Menninger at the time, did a study called Spontaneous Fluctuations in Hypnosis. They were doing hypnosis with people as part of research, and they would be very interested in, there were moments when the patient would say, I'm going deeper now. And they were interested, what happened? Why? What accounted? And so that's the kind of research that has always intrigued me. It's about context and giving tremendous weight to the context of what comes up and why it's coming up.
Speak, George, to your first proposal. You can definitely send resources or references, and I'm happy to forward them to the group after the webinar. Great.
There's one that's a very short paper. I sent it to Michal, I think, and to some about, and in a way, my whole talk is really from this very, very short paper. It's a commentary on the meta-analysis about interpretations and outcome. And the question I posed in this commentary is, why do interpretations account for so little variance in outcome? That was the question. And my answer, I did it in a very short, it's not like 2 or 3 pages long, but in a way, the essence of my whole talk today is basically contained in that very short paper. So I'll send that to you.
More comments.
One more question from
Yes.
Natalia Zubovich. Thank you for amazing lecture. You mentioned works of your colleague Sylvia, don't remember her second name, concerning interventions with narcissistic clients. Could you please send us reference to this work as well?
Oh yeah, I'd be very happy to. It's a wonderful paper.
Turn off the speaker.
Endangered by Interpretations, and it's
Well, there's a volume.
a really beautiful paper about why interpretations can actually be harmful to some people. The thing that she emphasizes in that paper, which is something I didn't really get into here, but it's a concept called treatment by attitude, that there are many, many psychotherapies where being able, where the attitude of the therapist is what accounts for the movement in the therapy. It's not what the therapist says or does, but it's having a particular attitude that is in itself therapeutic. And she talks about that in that paper. And there's another study that Marshall Bush did about psychoanalysts' own experiences of their own treatments and what they found helpful. And again, it was not the particular interventions, or it was more about how whether their therapist helped them in terms of accomplishing their goals and help them feel supported. It was a big part of the findings from that study. So.
Anastasia, do we have more questions, or is it time to wrap up?
No, Uli, no more questions. Everything else is thank you for interesting lecture. Thank you for the amazing lecture. Thank you for great information, and so on and so forth. So
Okay.
lots of thank you. Lots of gratitude.
Okay, so let me also, George, express my warmest gratitude to you on behalf of this SPR for Ukraine initiative. You have shared your wisdom and your thoughts. It's been well received by many and all of us. Thank you for your time, and I turn it over to Michal for some final words and outlook.
So let me just say, thank you. I appreciate the comments, but I also want to say how really privileged I feel. I was very, very touched by your invitation to present to our Ukrainian colleagues, and I feel very privileged to be able to talk with you today. So thank all of you.
Thank you also, George, for this wonderful lecture and very inspiring. I always, when I listen to you, I always think about also my patients and clinical background. And today a thought came to my mind that we as psychotherapists and also as societies create contexts in which also the patient meets with us. So perhaps this attitude is also the context we create with the patient. This is just an initial thought from today. So thank you very much for also this inspiration. And there were many questions considering where to hear more from you. And one source that you all can use are SPR conferences. And we have actually several coming soon. One will be in Ottawa. It will be in June this year. Then in Brno in Czech Republic, so quite close, in September this year. And then next year in Krakow in Poland. So actually 2 major events quite close to Ukraine. So do please come, feel invited. And we encourage you to join us there. And also, we have already plans for the next webinar within the SPR for Ukraine initiative. It will be on the 29th of May. 29th of May. So the title will be The Responsive Psychotherapist, how therapists from different approaches attune to their clients in the moment. So very interesting talk by Jane Watson and Hadass Wiseman. Jane Watson is from Toronto, from the University of Toronto, and Hadass Wiseman is from University of Haifa in Israel. So we invite you all to join us for the next webinar on 29th of May. And I will put it in chat so you can really have all the information there. You can copy it. It will be easier for you. And I'm sure that you will be able to hear more from George in several of the occasions that I've mentioned.
Thank you. Take care of everybody.
Дякую.
Thank you.
Thank you.
Дякуємо дуже-дуже.
Thanks a lot.